Right. So we are going to discuss for the next hour two interesting cases. This time they are not very challenging, but they have lots of educational values, and I'm very honored to have two distinguished panelists. I think they were both introduced yesterday, but briefly, Professor Elizabeth Pierce is a professor of medicine at Boston University School of Medicine and practicing endocrinologist at Boston Medical Center. She is also the director of the fellowship program there. And Professor Christine Bullard is a professor of endocrinology at the University of Birmingham, an honorary consultant at the University Hospital Birmingham NHS Foundation Trust. She's an internationally recognized expert in thyroid diseases, former president of the British Thyroid Association. Um, these panelists are very well known to you. They have contributed a lot. This is very, very, very minute things from their contribution to endocrinology and specifically to thyroidology. So as I mentioned, this is going to be an interactive session. So I would very much like you to participate. If you can scan this code or join through the web or even by sending SMS. So I'll just take a few seconds here to allow people to connect. You will have an opportunity again to connect when we have some questions. So just to test the system, here's a number of choices for your specialty. And every time we'll have a question, it will appear like this and then followed by, oh, not really. Okay, well, there's a little technical issue. Okay, let's move and see if this is only the next slide or we'll have it again. So the first case is a 15-year-old girl with no significant past medical history. She had her thyroid function test checked in the family medicine. Her father works in the hospital and he took her for just checkup. And you can see this was when she was at 9 years old. She had thyroid function test. The indication was not clear, but her FT4 was 16.4, which is quite normal. But she has subclinical hypothyroidism with a TSH of 9.4. Nothing was done. Even I did not find any evaluation for that. It was repeated again 3 years later, and it's showing the same picture. Nothing was done at that moment. And in 2022, she had thyroid function test, and the picture is a little bit different here. You can see that FT4 remained the same. However, TSH is on the low side. And again, 1 month later, I think at that time they start to be concerned. She had a repeat thyroid function test. And although the TSH has improved slightly, but it remained actually below the normal range. And FT4 was lowish or on the low side, still normal, but on the low side. You can see the T3 also at one time it was high. And to give you more information about this little girl, this is her antibodies. So anti-thyroglobulin and anti-TPO antibody are significantly high. So she's having some autoimmune thyroid disease. And the question here, with this picture in mind and the age of the patient, and I must say also her father has Hashimoto's thyroiditis, what is her risk of developing overt hypothyroidism, overt hyperthyroidism, either, but hypothyroidism is more likely, either, but hyperthyroidism is more likely, or she has minimal risk of either. Which one of those would be the best to characterize her risk in the future? And I think now the system is working. So please go ahead and tell us, what do you think her risk is most? Okay. So as expected, we have different choices here and different answers. The majority think that she could develop either, but hypothyroidism is more likely. I would invite Christine at this time to comment on this question.
Yeah, I think I probably would have gone for answer C as well, with raised thyroglobulin and raised TPO antibodies, fluctuating TSH. I know it's now sort of going the other way, and I know in young people it can be more fluctuant, but given these options here, I would have also gone for C. But I think she could develop either.
Okay, great.
Elizabeth, and I take it we didn't have TSH receptor antibodies at this stage. Right. Is that correct? We don't have a measurement of that?
Which one?
TSH receptor antibodies or
no,
TSI?
We don't have it yet at that time. Okay, Elizabeth, you have any comment on this?
No, just that I think this is a patient who is highly likely to develop more thyroid dysfunction in the future, and probably a scenario where I'd want the patient and the family to be sort of well educated about what symptoms to watch for that should prompt additional testing.
Okay, so this is a slide that shows us the usual progression of subclinical hypothyroidism that she had initially. Subclinical hypothyroidism with normal FT4 and mildly elevated TSH most commonly revert to normal over time, but there is a risk of 2 to 5% per year to develop overt hypothyroidism, and rarely hyperthyroid conversion can happen. So you can see here at the bottom, overall, there is around 3.5 per 1,000 women and much less occurrence in men. And there's a relationship also between this risk and the presence of anti-TPO and also the level of TSH. So the higher the TSH, the more likely that the patient will develop overt hypothyroidism, especially if TPO antibody are positive. You can see when TSH is between 6 and 10 and TPO is positive, the risk over the next 10 years is around 60%. And when the TSH is quite high, the risk is even higher, around 80%. Anyway, the first evaluation of this patient was at age 12 in 2022. She was seen by a pediatric endocrinologist. She diagnosed her as Hashimoto's thyroiditis. And she said she's at risk of overt hypothyroidism, and she recommended TSH every 3 months, which I think is a little bit exaggerated. But anyway, she is under medical care and medical surveillance. Everything was fine at age 14 in November, between November, December 2024. She was 14 years of age, and she presented with palpitation, dizziness for 3 weeks. And her physical examination showed that she was quite thyrotoxic with a pulse of 125, blood pressure with wide pulse pressure. She was anxious, tremulous, warm and sweaty skin, hyperreflexia. Fortunately, she did not have any evidence of proptosis, but she had lid lag and retraction, as you would expect. She had moist skin, no rashes, no pretibial myxedema, and the nails were normal. And just to confirm that clinical impression, her FT4 was more than 100 and TSH was suppressed. So the question now, is this Graves' disease? Is this just transient painless thyroiditis because of her autoimmunity? Is this subacute thyroiditis? Let's have a quick vote on this. What do you think is happening? Anybody would like to participate here? Okay. We see only Graves' disease. She is definitely at risk of painless thyroiditis. The only thing against that is the severity, biochemical and clinical. So only a few people choose painless thyroiditis. Elizabeth, what do you think?
I think this is almost certainly Graves'. As you know, typically the thyrotoxicosis is not as severe in painless thyroiditis as it is in Graves' disease. And subacute thyroiditis, I think, is off the table. We know she has thyroid autoimmunity and she's not presenting with thyroid pain.
Absolutely. And to confirm that, we did a scan, or she had a scan. I was not looking after her at that time, but she had a scan appropriately. And you can see diffuse uptake. And the uptake at 4 hours and 24 hours was very, very high. The normal uptake in our hospital at 24 hours, 25 to 35%, and this is 76%. So this is Graves' disease. And if you're not convinced, this is the anti-TSH receptor antibodies, quite high, 28, with a normal less than 2. So this patient, not unexpectedly, but the expectation that she will go into hypothyroidism, but she presented with Graves' disease. And the question, how are we going to manage this patient? And think about it. Should we give her methimazole or carbimazole for 1 to 2 years, or PTU for 1 to 2 years? Should we extend the period, use either of them, and just give her more time to recover, 3 to 5 years? Or should we just go ahead and do thyroidectomy when she becomes euthyroid using one of those drugs? Or should we go to radioactive iodine? Remember, she's 14 years. She has Graves' disease. It's quite severe. And she has large goiter. Okay, so let's see how people would approach an adolescent with Graves' disease of this severity. So far, methimazole is the preferred approach for 1 to 2 years. Some people would like to use send her for surgery, radioactive iodine. I'll just give a little bit of time. Maybe people are having difficulty logging in. PTU or methimazole for 3 to 5 years. Okay, so I think the main question here is the management of this patient. And I will again go back to Christine and ask how she would manage this patient at this stage.
Yeah, I don't really look after adolescents. I'm not really allowed to treat anyone below 16, but I think for me, the management here would be with methimazole. I don't think in someone who has such significantly raised TRAb and is that young, that a year of methimazole is going to cure this. It's going to need a minimum of 2 years, but possibly longer. I think I would keep thyroidectomy and radioactive iodine sort of at the back of my mind. And I think, as this audience well knows, there is actually a warning out against using PTU in children and adolescents. So I would feel very reluctant to do this. So, I think I'm between A and C. So I would definitely go, C in that I would use the methimazole. I think it will need a minimum of 2 years, possibly longer.
Okay,
and I think it's possibly
Elizabeth
unlikely will induce remission.
Sure. Elizabeth.
I absolutely agree. I've been fooled so many times by Graves' disease. It doesn't always do what you think it's going to do. So I have learned to not prognosticate too much. So I would probably tell my patient up front that we're going to treat you for a minimum of a year to a year and a half and see how the disorder responds.
Okay, great. Let's see. Okay. So at that time, she was actually evaluated by the family physician, and she started her on methimazole 20 milligram TID. She was severely hyperthyroid, but I think this is also very aggressive management. And she put her also on propranolol 20 milligram TID. And she came back in 3 weeks with severe skin rash, swelling of the face and lips, probably angioedema, and even shortness of breath. So she had severe side effects from methimazole. And the good news is that her FT4, which was above the upper limit of normal, more than 100, is now 25. And what should we do? Maybe I should ask again, Elizabeth, if you have this situation, what would you do?
So obviously, I think it's not safe to continue the methimazole. This is not just minor rash. This sounds like a much more significant allergic reaction. That shortness of breath is very concerning. There is some risk of cross-reactivity if, you switch to PTU. She may have an allergy, she may not. I probably would push for definitive therapy at this point as my first choice.
Christine?
Yeah, so I think to note, I think that's a high dose of methimazole to start. I know it was severe hypothyroidism, but I think that's a high dose. I guess she would have developed the reaction regardless of, I would probably have started 40 milligrams, and I usually use methimazole as a once daily dose. So that's one thing to note. But like Elizabeth, I mean, I feel I have seen some, not in this age group, but I've seen some very devastating effects from PTU, and I really am always, unless I have no choice, reluctant to use PTU. So I think definitive treatment is what's needed here.
I agree. Okay, so this is just the thyroid function test, and going from down upwards. The treatment started in December 24, and then by the third week of December, sorry, from the December 24th, 2nd of December, and then by 22nd, she had FT4 decreased down to 25, but she has this rash. So methimazole was stopped, and as suggested, the family were counseled on radioactive iodine surgery, but after a long discussion, and I was not involved at that time, they still preferred medication, anti-thyroid medication. So the endocrinologist who saw her was very careful to start on a small dose, especially her FT4 was only 25. She was starting on PTU 50 BID, but the dose needed to be gradually increased to 150 milligram TID, which is quite a large dose. Again, this is 450 milligram per day. Fortunately, she did not have the same skin rash despite the cross-reactivity, and she did not have any other side effects. But by mid-2025, we start to see liver enzyme increasing. And just to cut the long story short, you can see this is the start of her treatment. Where is that? Yes. Yeah, here. She started earlier. She normalized here. She was shifted to PTU. PTU was increased. She has not achieved euthyroidism most of the time. Part of it is the severity of her condition. Part of it is the compliance of a 15-year-old girl. And then with that, we start to see also liver enzyme increase by August 2025. And it was really concerning, but again, the family was very reluctant to the idea of radioactive iodine, and we were watching this very carefully, and it remained acceptable, in acceptable level. So now it's 1 year, and you have seen the level of thyroid hormones. We really achieved the euthyroidism in this young girl. And the question, what should we do next? Should we continue PTU for another 6 months? If you remember earlier, we were discussing that a minimum of 2 years in this patient. Try methimazole again at a smaller dose, proceed with thyroidectomy, or go for radioactive iodine. So let's give it a chance again. Okay. So we have again here almost division between all the possibilities, which tells you that the difficulty of managing patients with this scenario. While our colleagues are choosing, making up their minds. Again, Elizabeth, what would you do now after 1 year of PTU at 450 milligram and some elevation in liver enzymes?
So I would note that at baseline in most people with Graves' hyperthyroidism, there is some mild abnormalities usually, or even more significant abnormalities of transaminases, even up to 4 to 5 times normal. And I feel comfortable starting anti-thyroid drug when there is some transaminitis, but unequivocally that should get better as hyperthyroidism improves. It should not be worsening. So there's strong likelihood that this is PTU-induced liver dysfunction, and I think it's absolutely essential at this point to stop the PTU. You know, there's a risk that this could progress to fulminant hepatic failure. I think methimazole is also off the table. She had severe allergy to methimazole, so I don't think that's safe. So I think the options really that make sense, it would have to be definitive therapy, and it would be a discussion with the patient and her family about whether that would be thyroidectomy or radioactive iodine. My bias sometimes tends to be a bit more toward thyroidectomy as long as you have access to really experienced surgeons.
Okay, Christine, what would you do in London?
Birmingham, but yeah, probably
Birmingham.
she'd be heading for a thyroidectomy just because we have an excellent surgeon. We get rapid control of the situation here. I'm with Elizabeth that I think both anti-thyroid drugs are off here. Like I said, I'm always nervous, PTU, and I would be super nervous in this patient. So no more anti-thyroid drugs. And I think it's a discussion, and depending on where you work and what your provision is, I think radioactive iodine or surgery are both very acceptable options. And I think a further thing to consider is that even if you continue or are brave enough to continue anti-thyroid drugs here, they're not going to induce a remission in this patient. I think that's highly unlikely with that pattern of thyroid function tests.
Exactly right. So that's what happens in January 2026. That's just 3 months ago. I had a long discussion with the family. I was involved in the management of this patient around 6 months ago. And from day one, I was discussing some definitive therapy because she has large goiter. She has difficulty in taking medication regularly. She was on a large dose, liver enzymes increasing. So I was worried that we are sitting on a time bomb, and I didn't like it, but the family were hoping, and then they start to come along. So we had a long discussion with the family, and we discussed two options. One is surgery, radioactive iodine. They agreed on either of them. So we said, okay, you have more time to think because now we have to get the thyroid function under control, complete control for either of them. So you have 1 month. We emphasize compliance, and she took PT 150 TID regularly and was closely monitored with repeated thyroid function tests, CBC, and liver function tests during this month. By early February 2026, she was euthyroid clinically and biochemically. As I mentioned, her clinical examination showed very, very large goiter. Is at least 4 times the upper limit of, or 4 times the normal size. Fortunately, she does not have any signs of thyroid eye disease. And we discussed it together, although initially I wanted to send her for surgery, but I was concerned that our surgeon may not be as experienced. And I was really thinking twice about the possibility of permanent hypoparathyroidism or even recurrent laryngeal nerve. And the family were also not very enthusiastic about surgery. So we ended up sending this patient to for radioactive iodine. And this is what happened. She received 60 millicurie on 10th of February this year. I kept her in PTU at smaller dose, 100 milligram TID. I was actually worried about exacerbation and about eye, so I covered her with a steroid for a couple of weeks, just 2 weeks actually. We started with 30 milligram for 1 week and then 20 milligram for another week. Once I was assured that her thyroid function was not going up, I stopped it. And actually I stopped PTU here. And as you can see, her thyroid function test up till this time is normal without any intervention. And I hope she is scheduled for another thyroid function test and liver function test next week. The good news also is that her liver function test normalized with a reduction in PTU and then discontinuation of it. So this is basically what the end of this case. I just want to briefly yeah, we have time. Just show you the general approach for management of Graves' disease in children and adolescents based in the European Thyroid Association guidelines and some excellent reviews. So the anti-thyroid medication obviously is the first line of therapy. Methimazole is preferred over PTU. The risk of hepatotoxicity is much higher in children when they use PTU. However, the overall remission rate is only around 20 to 30% after standard 2-year course. It is lower than in adults, and up to 50% if you continue it for 5 to 10 years, which is probably not practical. As I mentioned, the remission rate overall is lower than the adults, and the side effects are very well known. However, hepatotoxicity is probably much more or significantly more in children from PTU and even methimazole. Thyroidectomy is actually preferred definite treatment in children in general, especially when they are less than 10 years of age. This is the recommendation by the European Thyroid Association, but there are certain indication for this, including anti-thyroid drug failure or severe side effects, large goiter like this patient, or compressive symptoms, and again, the preference of the family and the patient. We should always aim for near total or total thyroidectomy, not partial thyroidectomy, because of the risk of recurrence. And obviously, the cure rate is very high. The problem is the side effects, as we just mentioned, but in a very good hand, they're minimal. And finally, radioactive iodine in children, it's considered to be selective and second line, especially for patients less than 10 years of age. When they are more than 10 years, it has its own place. It's good for small and moderate goiter. And when the surgical risk is high or you're concerned about it, like in my case, contraindication obviously is young age or severe eye or active thyroid eye disease in pregnancy. And the outcome overall is around 86% cure in adolescents. Most of them will be hypothyroid. I must say, in my patient, I'm concerned that, and I told her family that I hope one dose will be enough, because really she has large goiter. So time will tell as we go. Any final comments by our distinguished panelists here, Christine or Elizabeth, on this case before we move to the next one?
Yeah, a couple of things I wanted to comment on. So because she has a large goiter, I might have leaned more towards surgery, but I realized that that's then also more complicated surgery and therefore potentially more likely to side effects. I think the other, because like I said, I would be very nervous continuing any form of anti-thyroid drugs here. And if you go for surgery, then of course you can give Lugol's-iodine and get it under control before surgery. So I think that gives a further advantage. And I note on her most recent thyroid function test that her TSH still remains undetectable. So like you say, I wouldn't be sure that she's cured actually.
It's only around 6 weeks now. We treated her on the 10th of February. Yeah. Elizabeth?
I don't think I have anything to add to Christine's comments. Just glad she finally got her definitive therapy.
Yeah, I'm quite happy. I mean, I'm quite happy taking care of 450 milligram PTU, and I hope she will do fine. Okay, so with that, let's move to the second case. If we have time at the end of the second case, we will see if there are any questions from the audience. But let's move on with our planned agenda. So case number 2 is a 38-year-old Filipino nurse in our hospital. She was initially seen in 1985, so long time ago. She had symptoms of hypothyroidism, weight gain, cold intolerance, fatigue, and she had small goiter, as per the note, and she was hypothyroid, and TSH was 58. She was diagnosed as Hashimoto's thyroiditis, started on thyroxine 100 microgram daily. And between 1985 and 1993, she was on thyroxine, not always compliant, with sometimes an elevation in TSH of up to 15, at another time 38. So she was definitely having Hashimoto's, and actually her antibodies are positive. In 1993, she went on leave on a long vacation, 6 weeks. She went to Australia, and she forgot to take her thyroxine, but she did not care, and she did not have any symptoms. She was asymptomatic. And when she came back after 6 weeks, she had the thyroid function test, and surprisingly, her thyroid function tests were normal. So TSH was actually on the low side, FT4 was normal. and antimicrosomal or anti-TPO antibody was elevated. And the endocrinologist at that time said, okay, let's repeat this in another 6 weeks, repeated many times over the next 2 years, and she remained completely euthyroid. So between 1994 and 1998, she was euthyroid. And the question here, again, for the audience is how frequent we see this scenario, a patient who is hypothyroid converting after actually many years, converting to euthyroidism. And I'm giving here some percentages, and I know it's difficult without knowing the literature, but let's give it a shot. So how frequent people who are having chronic hypothyroidism go back to euthyroidism? 5%, most people. 15%, few. Somebody choose 35%. Okay. So Elizabeth, how frequent do you see this in your practice?
This is pretty uncommon. So somebody with baseline subclinical hypothyroidism often, as you noted, in fact, the majority of the time will revert to euthyroidism over time. But somebody with long-standing overt hypothyroidism is very unexpected. Mostly we sort of expect Hashimoto's to progress to apoptosis of the thyroid, and that dead thyroid is usually not going to come back.
Agree. Christine, is your experience different?
No, it's exactly the same, Ayu. So I would have been in the 5% camp and potentially less than that.
Okay. So normally when somebody is having overt hypothyroidism, we don't think to stop thyroxine. We assume that this is permanent, and for the most part, it is permanent actually. But what does the literature say? This is a meta-analysis of 17 studies published in Thyroid 2021. And I was actually surprised to see that 37% of patients revert to euthyroidism. However, most of those are subclinical hypothyroidism. For patients with overt hypothyroidism, 12% in this meta-analysis went back to euthyroidism, which I think also is more than expected, but at least it's not as high as this. So this is the trajectory of Hashimoto's thyroiditis. Long-term, 50% will continue to have permanent hypothyroidism. 35% will have stable euthyroidism. They will convert. And some patients will have fluctuation in their thyroid function test. And even a very, very small minority may become hyperthyroid. And these are the predictors of spontaneous recovery from hypothyroidism. If there is a goiter, the chance is higher because goiter has some thyroxine. There's some reserve there. So you can see 80% reversal compared to 34% non-goiterous Hashimoto's. If you happen to do thyroid radioactive iodine uptake and it is high, it's more likely, the chance is more likely for euthyroidism. If thyroid binding antibodies disappear, obviously the autoimmunity decreases and there might be recovery. Iodine restriction in high iodine intake population can lead to euthyroidism. And then atrophic thyroiditis is less likely to result in permanent hypothyroidism. But anyway, the message here is that some patients, and I think it's even less than 12%, but again, in these 17 studies, up to 12% of patients with overt hypothyroidism can normalize their thyroid function test. So just to remind you about our patient, hypothyroidism in 1985 continued to be so until 1993. Euthyroidism discovered by chance due to non-compliance. And then she continued to be euthyroid over the year. But in 1999, something else happened. This is what happened. She came with palpitation, heat intolerance, sweating, and insomnia. And clinically, she was thyrotoxic with tachycardia, tremor, lid lag, and 30-gram non-tender diffuse goiter and brewing. And her lab showed mild to moderate hyperthyroidism with FT4 of 31, normally is up to 22, and suppressed TSH. And she had scan at that time, and it was elevated. Again, now the upper limit for our uptake is 35. She had 41%. So she developed Graves' disease. And you can see the timeline from hypothyroidism for years to euthyroidism for a year, and now she's coming with Graves' disease. So the question again, how we are going to manage this patient? Should we just observe her, especially that she has mild hypothyroidism, and see if she is going to normalize? Maybe give her some beta blockers, methimazole followed by radioactive iodine, give radioactive iodine right away, or send her for surgery. And again, let's see how our colleagues, the audience, think about this case management. All right. Okay, so 55% will give her methimazole, 40 will observe her, and around 15% will send her for surgery. Few will give her methimazole before radioactive iodine. Nobody would give her radioactive iodine directly. Christine, what do you think?
I'd probably put her on a low dose of methimazole.
Low dose of methimazole.
And see what the response is.
Are you planning to continue that for like a year or 2 years?
Yeah. I'd start her on it and give her a 12 to 18-month course and then see what happens. Is
Elizabeth.
what I would suggest.
Yeah, I would probably do the same. Although I'd note, I think there are a couple things about this patient that give you hints that this could be problematic. It's sort of presumed. We know now that she has TSH receptor stimulating antibodies. I think we can infer that she probably also in the past was hypothyroid due to blocking antibodies. So if both are present and are sort of shifting back and forth, you have a sense that this might be one of those patients who could continue to kind of shift back and forth and be hard to predict. So I probably would start with methimazole, but in these patients where you think you might have these back and forth shifting antibodies, sometimes radioactive iodine during a hyperthyroid phase is not a bad thing to do.
Okay, great. I must say, I saw her, when was that? In 1999. I was actually a young endocrinologist at that time, just came back from US, and I must say at that time, radioactive iodine was the standard in US. So affected by that idea, I was enthusiastic to give her radioactive iodine. So I put her on some methimazole, and then I sent her for radioactive iodine. I think the overall approach now in the United States has changed more towards anti-thyroid medication, or radioactive iodine used to be the standard of treatment for 90% of patients with Graves' disease, but I believe now it's less. Is that correct, Elizabeth?
That's correct. I think the US practice is now more in line with the rest of the world, and methimazole's first line.
Okay, great. All right, so here's another question. If she's treated with radioactive iodine, does she really need anti-thyroid medication before radioactive iodine? If we decide to give her radioactive iodine, she's 38, she has no more comorbidities, and she has relatively mild to moderate hyperthyroidism. So the question, should we give her methimazole before sending her for radioactive iodine? And you can see the answers. No, she's young and healthy. Yes, it doesn't matter, or I'm not sure. Let's see what our colleagues here think. People seems to have already chosen answers, okay? So the majority will give her methimazole before, or establish euthyroidism before sending her for radioactive iodine. But some choose actually to send her right away for radioactive iodine. Few do not mind, and some are not sure. So again, Christine, what do you think?
I treat most of my patients with methimazole prior to radioactive iodine. So, as a reflex, I would do it. I think as it's mild here, it's so when I did my sabbatical at the Mayo Clinic, I saw patients who were quite thyrotoxic just given radioiodine, which is not something we do in the UK. But to be honest, they were fine. But so yeah, my reflex action would be to give her a low dose of metimazole prior to radioiodine.
Elizabeth, would you do something different?
I would generally do the same. You know, if it's overt hyperthyroidism, I usually pre-treat.
Okay, so that's what I did. I put her metimazole, 20 milligram. 3 weeks later, she was feeling well. Her thyroid function test was almost normal. T3 was normal. TSH was obviously still suppressed. And I treated her with radioactive iodine. They probably gave her more than what she needed, but anyway, the dose was 40 millicurie. And I decreased the dose of metimazole, restarted it again after 3 days of after radioactive iodine, 10 milligram daily. And everything was expected to be fine, but 5 weeks later, she came with palpitation, heat intolerance, tremor, headache, nausea, vomiting. In fact, she was severely thyrotoxic. She had tachycardia, she has a bit of temperature, she was irritable, she was fully conscious, oriented, but very, very anxious. The goiter was tender, and I wanted to admit her. She did not want to be admitted because I actually thought that she has impending thyroid storm. This is her thyroid function test. The FT4 is more than the upper limit of normal. T3 was quite high and TSH suppressed. So she had severe thyrotoxicosis with impending thyroid storm. So I increased her metimazole to 50 milligram 3 times per day. I wanted to admit her. She refused completely. I put her in propranolol, 40 milligram every 6 hours, gave her local solution, and again, she refused steroids. I was actually treating her as impending thyroid storm as an outpatient because she did not want to come in. And actually, after 3 days, she was feeling much better. Her FT4 declined to, I think, 48, yes. And basically, things went on, and after another 2 months, roughly, she became hypothyroid, and she needed thyroxine. So she had this severe hyperthyroidism after radioactive iodine. And the question again goes back to the same thing. Do we need to establish euthyroidism before radioactive iodine? I think we answered that question, but let me just quickly look at the ATA guideline 2016. They have some recommendation about this. This is a bit of controversial subject. There are studies suggesting that it is important. Other studies think that if the patient is healthy and has no comorbidity, they can go for radioactive iodine. My practice is similar to your practice, Christine and Elizabeth. I almost always establish youth, or at least make them close to euthyroidism. The recommendation here, because radioactive iodine treatment of Graves' disease can cause transient exacerbation of hyperthyroidism, beta adrenergic blockade should be considered even in asymptomatic patients who are at increased risk for complication due to worsening of hyperthyroidism. And that includes elderly patients with comorbidities. So beta blockers seems to be an important element of the post-radioactive iodine management. And the second thing, in addition to beta blockade, pre-treatment with metimazole prior to radioactive iodine for Graves' disease should be considered in patients who are at an increased risk for complication due to worsening of hyperthyroidism. And it should be discontinued 2 to 3 days prior to radioactive iodine. Recommendation number 6 in this guidelines, in patients who are at increased risk for complication due to worsening of hyperthyroidism, you should resume metimazole 3 to 7 days after radioactive iodine administration. And final recommendation here is medical therapy for any comorbid condition should be optimized prior to radioactive iodine. And I think this is an important point. If somebody's in congestive heart failure, you don't want to give them a radioactive iodine before you make sure that his cardiac function is fine. So this is what happened with this unusual patient. Again, between 1985 to 1993, classic Hashimoto's. then she recovered and became euthyroid for many years. And then she presented Graves' disease. And again, part of her unusual course, she developed severe hyperthyroidism after radioactive iodine with a transition between hyper and hypothyroidism. And finally, she became hypothyroid, and she's on thyroxine, currently 100 microgram most day. And again, I just looked at the literature of patients who have spontaneous alteration in autoimmune thyroid disease. As mentioned earlier, it is rare, around 6% in this study, which is basically 2 out of 34 patients who were chronically hypothyroid and became hyperthyroid. It is even lower, less likely if a patient was hyperthyroid to spontaneously go into hypothyroidism. This is again 2 patients out of 98 patients. And again, less than 50 published cases similar to the case we described today. You can see here those cases. So I give the floor for Christine and then Elizabeth for final comments on this.